I'd like to thank John for the invitation and for letting me go last. The way I figure there'll be less people around to bear witness to any missteps I make, so thank you, John. The topic I was given was when all else fails, LVADs, and certain, oh, here's my disclosures, I'm sorry. We all know that in the old Westerns, when someone was in trouble, it was the cavalry that was called to come and save the day. However, they can't come to the hospital when we have patients with cardiovascular problems. And so when there are patients who are hypotensive and in shock, it's the cardiac surgeons who are called. And we have a long and somewhat glorious history of doing that. And we have a whole bunch of different toys that are at our disposal to use in that situation. And so we're going to talk about that a bit today. We've been using a variety of different mechanical devices since the early 60s to take care of acute cardiogenic shock, as well as a bridge to transplantation and destination therapy for about the past 15 years. And the outcomes have been progressively improved in all categories. And there's indications for both acute and for chronic use of left ventricular assist devices, and in the sake of time I will concentrate primarily on the acute indications, both for cardiogenic shock and post-cardiotomy failure, and if I'm able to get the last few slides in at the end, we'll talk about some of the chronic indications. Well, certainly I want to talk about the problem that generates the need for this. I will talk about the pathophysiology, review the therapeutic indication short of ventricular assist device and how they do, and I'll discuss the role of VADs in support for acute indications for surgery. Well, the clinical spectrum of coronary disease is quite broad. You have everything from stable angina to ST elevation myocardial infarction. And in that later group of ST elevation myocardial infarctions, we know that between 7 and 10% suffer cardiovascular shock. And it's these people who have cardiovascular shock that we're going to be talking about today. This means about 70 to 100,000 patients per year in the United States. And we know that cardiogenic shock is the leading cause of death following infarction. Now, if we go back and look at the shock trial, we learned that revascularizing patients acutely improves outcome compared to medical therapy alone. We know that acutely within the first month, there's about a 10% improvement with revascularization, but we also know that the early mortality with revascularization is still about 50%, and that mortality is higher if you present with cardiogenic shock or you develop it within the first 24 hours. And this holds true when you follow these same patients out a little bit further. We know that after the patients are discharged for the hospital within the first year, there's about a 15% improvement overall, and this carries out for about 10 years. And so with this high mortality, we still have to think about other things that we can do besides revascularization. And certainly that's where balloon pump counterpulsation comes in. We all know about balloon pumps. We know the pathophysiology and the benefits. And we also know the problems with that. However, it's a very useful tool, and we'll talk about some of the data that's out there regarding the use of balloon pumps in acute shock. This is a paper that was published just 5 years ago and looked at several different types of papers regarding the use of intra-aortic balloon counterpulsation in post-myocardial infarction shock. There's randomized and observational studies, and overall you can see that the range of mortality benefit is from 20 to 50% reduction in mortality. And I'd like you to concentrate on the NRMI, the National Registry of Myocardial Infarction data, because this demonstrates quite nicely the conundrum we have when we're dealing with the impact of balloon pumps on outcomes following cardiogenic shock for infarction. And this slide just shows those patients who've either received thrombolytic therapy, TT, or PTCA on the right. And you can see that following thrombolytic therapy, there is a very significant benefit in mortality. However, following PTCA, there is not. And there's a conundrum there. Why is there not a benefit? And in this entire series of about 23,000 patients post-MI with cardiogenic shock, about a third of them did receive balloon pumps. So it's a rather vigorous population. Well, there are several different meta-analyses in the literature. This is one that was in the European Heart Journal 2 years ago that looked at 9 different studies which accrued about 10,500 patients. And it includes both patients who received no reperfusion therapy, thrombolysis, and primary PCI. And you can see for the people who did not receive any revascularization, there's a very significant benefit to using balloon pump, shown down here, and no balloon pump on the right. And in those people who underwent thrombolysis, there's again about a 20% benefit in using it. However, in patients who have been revascularized, there is no benefit. And because of that, overall, there really isn't a benefit in 33,000 patients who were looked at who've received a balloon pump. Now, what I can tell you from spending a couple weeks looking at this literature is these studies are very poorly controlled. There are tremendous inconsistencies of the definition of cardiogenic shock in this literature, and we all know that there's shock and then there's shock, and it is very poorly controlled in this population of studies, and the patient management varies dramatically in these cohorts of patients who are evaluated. So we have to keep that in mind. And one of the things that really demonstrates it nicely is in the National Registry of Myocardial Infarction, again, a sub-study that was published by Chen in Circulation about 10 years ago. He looked at dectiles of use of intra-aortic balloon pump and the outcomes of patients who have balloon pumps placed for post-infarction cardiogenic shock. So these are people who use balloon pumps to a greater extent on the right. And in fact, just like most of what we do as surgeons, those people who use balloon pumps more commonly for cardiogenic shock following infarctions have the best outcomes. But it's still about 50% mortality in this group of patients. So the recommendations post-MI from the ACC and for the European Society of Cardiology is that, number one, you revascularize these patients right away. Number two, you put a balloon pump in for people who develop cardiogenic shock. But yet this recommendation is made knowing that there's some concern about the level of evidence that there is, and that in-hospital mortality is still about 50%. And that's where the surgical VADs come in. There's a whole group of devices that have been used and will be continuously used in the future. And we'll look at both the open surgical VADs as well as those that are put in percutaneously. There are many different reports out there that document the usefulness of VADs for cardiogenic shock, but I want to talk about the literature a little bit and let you know up front, there are no prospective randomized multi-center trials. The literature is not clean, and that's something that we have to come to grips with, and we are criticized for that. Most of the patients in the literature who receive shock are in the second group that I mentioned. They have real shock. It's not just a little bit of low blood pressure. These are patients with real shock. However, despite that, the European Society of Intensive Care Medicine does recommend that in patients who have shock, that left ventricular assist devices, or ECMO, are used for these patients. And interestingly, this is not mentioned in the ACC, American Heart Association guidelines. This is a study from the Cleveland Clinic where they looked at about 140 patients over 5 years, and they looked at patients based on how aggressive they were treated following their infarction. The lower curve represents those patients who were treated with medical management, and what they termed at the time aggressive therapy are the patients who received either PCI or CABG or ECMO. And based on this small cohort of patients, there's a very significant improvement in outcome the more aggressive the therapy was. And in the patients who received PCI or CABG but did not receive anything more than that in terms of mechanical circulatory support, the in-hospital mortality was still about 60%, whereas that group of patients who received more advanced aggressive care, the mortality was about a third. There's a lot of experience with pulsatile pumps and has been up until the past several years, and probably the most commonly used pulsatile pump today is the AB 5000 pump. In a paper that Mark Anderson published last year in the Annals of Thoracic Surgery, it looked at the first 100 patients who had used this pump for acute cardiogenic shock. And about 50% of these patients survived. But what's interesting about this group of patients, this is the survival out to 2 years with the confidence intervals shown here, is that in this group of patients who survived, about 65% of these patients had very significant or complete myocardial recovery and were out of heart failure. The other thing that this study showed us and caused us to start thinking about this a little bit is that the duration of support for the patients who received pumps in this study was 25 days, far longer than what most of us considered using in patients typically. And this may be reflected in some of the outcomes that we can improve upon. This is a mixed review that was published in SIO. And if you look at the duration of therapy for these many different devices, ranging from ECMO and Abiomeds to Impellas and hemopumps, it's in terms of hours. And when you look at the outcomes, either weaning or survival, around half of the patients were able to be weaned, and somewhere between 30 to 50% survived. So perhaps with longer durations of therapy, we'll be able to have better outcomes. This is a study that looked, from the University of Pennsylvania, that looked at using devices in acute cardiogenic shock in patients who have acute anterior myocardial infarctions and in those patients who have cardiogenic shock and have chronic ischemic cardiomyopathies. And this is over a 10-year period where they used approximately 80 pumps or so to support patients, and there's quite a variety of different pumps that were used. The thing they have in common is cardiogenic shock and an apical ventricular cannulation. And what you can see in this study is that in both groups, about 60 to 70% of the patients survived to be transplanted. And you can also see that the 30-day mortality and in-hospital mortality are improved compared to other groups of patients with cardiogenic shock. Now, when we switch over to start discussing the continuous flow VADs, Ranjit John at the University of Minnesota published a series of patients that we all as surgeons deal with. These are the patients that get sent to you either from an outside institution or from your own cath lab where the patients are in shock, they're developing multi-organ failure, and they either have biventricular devices in or you put the devices in. And he looked at the outcomes, and he used the CentraMag device, which is a new continuous maglev pump, and he looked at whether these pumps were either explanted, whether they were able to have a bridge-to-bridge, or whether they passed away, and he found that 83% of these patients, and this is a disaster population of patients, as you and I can agree, 83% of these patients not only survived, but they survived out to 3 years. Well, now we're going to start to move into the more current era where we start to use percutaneous LVADs, and the two most commonly used ones are the tandem heart shown on the left of the screen, which requires a transseptal puncture, and the Impella 2.5, which is a percutaneously placed pump, which is an axillary flow pump, which can be used in a variety of situations. Both of these pumps are used most commonly in the cath lab, but have been used both for cardiogenic shock, post-cardiotomy, and as a bridge to a bridge. The thing about these pumps is they will not provide complete support. They're more analogous to what a balloon pump can do. Maybe they're super balloon pumps, but certainly the technology is out there and can provide useful benefit to groups of patients. This is a paper published in European Heart Journal which looked at how well these pumps do compared to percutaneous or balloon pumps versus percutaneous VADs. And they used the cardiac power index as a reflection of how the heart is doing and performing with either a balloon pump or a percutaneous VAD. This was a prospective randomized trial, and it did show a very significant improvement in cardiac performance with the percutaneous VAD. But what it didn't show was improved survival. And that was fairly interesting, but when you look at the cause of death in this small series, those people who had a percutaneous LVAD put in, none died of cardiac failure, and those who had a balloon pump all died of cardiac failure. Now, there has been one meta-analysis done of this comparison between balloon pumps and percutaneous VADs, and you can see both from a cardiac index, mean arterial pressure, and pulmonary wedge pressure, there's significant benefits in all of the studies that were looked at, up to 100 patients who received the tandem heart and the Impella in the percutaneous VAD. But again, no survival benefit. And in this meta-analysis, the lack of survival benefit was attributed to the fact that the complications in the percutaneous VADs was fourfold higher than complications related to the balloon pump in terms of bleeding and arteriotomy issues. Well, what's the data for using a VAD post-cardiotomy? Well, one study that demonstrates quite nicely is a recent review of the STS database where over 700,000 CABG patients were looked at. Those patients with preoperative cardiogenic shock constituted about 2% of those patients, but accounted for 14% of all the deaths. And the operative mortality in patients who go to the operating room with cardiogenic shock is very high, but it's also related to the operation that's done. Now, if you looked at all patients in this series, there is a 22% mortality versus 3% when patients who were looked at in the STS database overall during this time period. When you looked at coronaries during this time period, cardiogenic shock 19%, CABG 2.3%. And similar differences hold for AVR CABG, mitral CABG, and acute VSD CABGs. So it's a very sick group of patients, so very clearly this group of patients needs the best cardiac output you can provide for them. So when should you use a VAD post-cardiotomy? Well, there are two studies that demonstrate nicely what happens when you don't, when you only use inotropes in a balloon pump. This is a paper that Lou Samuels published about 8 years ago in the Journal of Cardiac Surgery, when he looked at all patients who were operated on at Hahnemann University Hospital, about 3,400 patients, and looked at how they did based on what it took them to leave the operating room, on low-dose inotropes, moderate dose, 1, 2, or 3 dose inotropes. And you can see that patients who leave the operating room on 3 or more high-dose drugs, there's about an 80% 30-day mortality. Those who leave on low dose, the mortality is less than 5%. So very clearly, the more support you need to leave the operating room, the greater the risk of death in the first 30 days. The Berlin Heart Institute looked at their experience with balloon pumps, and they wanted to see how patients did who required a balloon pump to separate from bypass. And in their cohort of 11,000 patients, this was about 3.5% of the patients who underwent cardiac surgery during this time period. And they came up with a balloon pump prognostic score that looked at 4 discrete variables: epinephrine dose, urine output, mixed venous saturations, and left atrial pressure. And they came up with a score. Each of these received a 1 and then 2 times the dose of epinephrine. And what they found was that the higher your score, the less likely it is that you would survive. So if you had a score of 5, nobody survived. And if you had a score of 0, 81% of the patients survived. Now, if we want to look at the right side briefly, most of these pumps are used on the right side and the left side, but we now have a percutaneous RVAD designed specifically for that experience. It's been used once. It's the Impella RP device, and it has 1 survivor and 1 patient used, but we have used both the tandem heart and the other Impellas on the right side in various configurations. So this is a busy slide, but the algorithm for cardiogenic shock post-cardiotomy, start with inotropes, but when you have greater than 1 high-dose inotropes, a balloon pump can and probably should be inserted. If you have problems coming off within the first hour of going up on your inotrope, then consider a short-term pump. Any one is fine. They all can work equally well. It's what you and your institution can come up with. And most patients can get away with just left ventricular assist device support. If the LVAD's not working, you're probably going to need an RVAD as well, and then you end up with biventricular support. So very briefly, a couple of slides looking at chronic indications for LVADs nowadays. When we're talking about chronic heart failure, where cardiac surgeons become involved, is way at the end of the food chain in the stage D heart failure patients that are refractory to medical therapies, inotropes, and biventricular pacing. And really the 2 pumps that we use most commonly today, the HeartMate 2 device, which has been approved as therapy both for destination therapy and bridge to transplantation, and the outcomes with that trial are quite good. This is from a paper that Randy Starling just got published in in JACC, looking at HeartMate 2 patients in red, where there's 85% 1-year survival, in a contemporaneous group of patients who had other devices put in during this same time period. And what he found was that this continuous flow pump had about a 15% improved survival over the other devices used during that time period. And wanted to talk about results of destination therapy. This slide shows both the original rematch outcomes, where we showed that the pulsatile flow HeartMate XVE did better than medical therapy. At 2 years, there's a difference of about 20% in survival. And in the destination therapy paper that led to the approval for the HeartMate 2 device, we have 2-year survival of about 60% and still have 2-year survival with an XVE of about 20%, showing that it wasn't the care that got better, it was certainly the improvement in the device. What we did get better at is how we did perioperatively with this patient. If you look at the 30-day operative mortality in the current study that Randy Starling just published, our 30-day mortality, chronic heart failure using the HeartMate 2 device, is 4% versus 11% 30-day perioperative mortality from the original study for bridge to transplant. Well, there's a competitor on the block, and the early results with the heart wear pump are that it works fairly well. Recent data that was just published a couple weeks ago at the ISHLT showed that in both the advanced bridge to transplant study and the CAP extension, those are the continued access protocol, we have both 86% and 92% 1-year survival. So this pump works very effectively. It's still early to know how it's going to match up with the HeartMate 2 device, where there are cohorts of patients that are better served by one or the other, but this is a pump that's proved itself, at least early on, to be very effective in taking care of this group of patients. So finally, I'll conclude by noting that acute cardiogenic shock has a high mortality. Medical and surgical interventions do improve survival up to a certain point, and that point appears to be about 50% or maybe 40% hospital survival, and that the sickest patients, those patients with real shock, need to receive mechanical circulatory support, and that we may do our patients a better job if we keep these devices in for a longer period of time and don't rush to get them out, not only in survival, but in complete myocardial recovery. I'll end there and be willing to entertain any questions with the panel.